Welcome to Clinical Minute, Pregnancy Planning for Patients with Inflammatory Bowel Disease. Rachel is a 30-year-old gravida zero para zero Latina woman who was diagnosed with ulcerative colitis approximately 10 years ago when she was 20 years old. She currently takes oral corticosteroids for inflammation. Because of the corticosteroids, she is on long-term antibiotics for recurrent sinusitis. You note that over the past 10 years, she has received multiple courses of long-term antibiotics. Rachel is not currently taking any other medications. Based on Rachel's weight, you note that she has a body mass index of 18, and Rachel tells you that she is anemic. As you know how important pregnancy planning is for women with ulcerative colitis, you ask Rachel what her plans are for pregnancy over the next year, using the one key question. Do you want to become pregnant in the next year? Rachel tells you that she would like to become pregnant in the next year, but would like to delay for a few more months. However, she has heard that it can take a while to get pregnant for women who have inflammatory bowel disease, or IBD, so she plans to start trying soon. How do you counsel Rachel? You know that overall, fertility is generally not reduced in women with Crohn's disease or with ulcerative colitis. Active disease may lower fertility due to pelvic inflammation, poor nutrition, decreased libido, depression, or dyspareunia. Active disease is also associated with worse pregnancy outcomes, so women with IBD are encouraged to become pregnant only after ensuring that their disease is in remission. Surgery can also lower the rate of fertility in women with IBD, but Rachel has not had surgery, so this isn't a factor for her. You also know that in a meta-analysis evaluating the impact of IBD on fertility in non-surgically treated people with IBD, a reduction in pregnancy rates was noted for women with Crohn's disease, but not for women with ulcerative colitis, suggesting that IBD had little impact on fertility. Furthermore, the researchers reported that reduced fertility among women with Crohn's disease was linked to voluntary childlessness because women with the condition were choosing to not become pregnant. In this study, the researchers were unable to find a link between the physiological changes associated with IBD and the lower rates of pregnancy among women. When counseling Rachel, you begin by discussing the impact of IBD on fertility. You tell Rachel, I hear you saying that you have some concerns about fertility because of your ulcerative colitis. While it is a common belief that women with IBD cannot get pregnant or might have trouble getting pregnant, most studies have not supported this. You then tell Rachel that active disease may be indirectly associated with reduced fertility. You add that active disease is also associated with worse pregnancy outcomes, such as preterm birth and low birth weight. Since Rachel is currently experiencing active disease, you explain to Rachel that ideally she should wait for 3 to 6 months after controlling symptoms before considering pregnancy. Since it may take 3 to 6 months to get her symptoms under control, you would advise waiting 6 to 12 months before considering pregnancy. You ask Rachel about her opinion about trying to get her disease under control before becoming pregnant. Rachel says, well, it's not exactly what I had in mind, but I definitely don't want to have a difficult pregnancy on top of my IBD symptoms. I'm fine with waiting for a few more months than I had originally planned. Once you have discussed the importance of pregnancy timing with Rachel, you know that the next step is to work on controlling Rachel's symptoms with a corticosteroid-sparing regimen. You hope that modifying Rachel's treatment regimen to reduce or eliminate the corticosteroids will also allow eventual discontinuation of antibiotics, as you know that long courses of antibiotics are not recommended during pregnancy. There are currently limited studies assessing the safety of antibiotics during pregnancy, particularly for long-term use. While short courses of metronidazole and ciprofloxacin have been shown to be safe in small studies evaluating short-term impacts, such as preterm birth or birth defects, fewer studies exist for long-term impacts on childhood health. Some studies have shown that antibiotic therapy during pregnancy may be associated with an increased risk of childhood asthma, childhood epilepsy, and childhood obesity. The current hypothesis is that the findings are associated with the effect of antibiotics on the maternal and fetal microbiomes. Further research is needed, but you still aim to reduce Rachel's need for antibiotics prior to her pregnancy. In addition to Rachel's long-term antibiotic use, you also consider the impact of corticosteroid use during pregnancy. You know that corticosteroids are not contraindicated in pregnancy, but some concerns remain. Although corticosteroid use has not been shown to be associated with congenital abnormalities or risk of infant infections, there have been studies showing that corticosteroid use may be associated with gestational diabetes and low birth weight, and with an increased risk of preterm birth in women with active disease. Based on these data, you would like to taper Rachel off of corticosteroids if possible. If the corticosteroids are necessary to keep Rachel's disease in remission, however, corticosteroids will not preclude Rachel from planning a pregnancy. You know that you would like Rachel to be off of antibiotics and on a corticosteroid-sparing regimen prior to pregnancy. You tell Rachel that you would like to work with her gastroenterologist to discontinue antibiotics and corticosteroids if possible, and to start a new regimen with the goal of healing the colon. You say to Rachel there are a few different options that your gastroenterologist will likely discuss with you. These are anti-TNF agents and anti-integrin agents. Both treatments have been shown to reduce disease activity and induce remission. Because it is important that Rachel is completely informed, you also tell her that in some patients, these treatments do not work. You tell her that her other option is surgery, likely ileal pouch anal anastomosis, which involves removal of the large intestine and connection of the small intestine to the anus. You tell Rachel that this surgery avoids the need for an external ostomy bag, which she may be familiar with based on her own research. You then tell Rachel, if you choose to undergo surgery, there is a chance that your ability to get pregnant may be reduced. Studies are inconsistent, so I can't tell you precisely what your chances are of getting pregnant following surgery. However, most studies agree that the risk of infertility increases approximately threefold, meaning you are 3 times less likely to be able to conceive on your own. You reiterate the varied results found in the literature and explain that likely this decreased fertility rate is due to scar tissue in the pelvis. After discussing pregnancy planning and symptom control with Rachel, you begin considering how she will prevent pregnancy until she is ready. You know that some studies have suggested that oral contraceptives may not be properly absorbed by women who have IBD due to extensive ulceration and inflammation of the gastrointestinal tract. While pharmacokinetic studies have revealed that there was no difference in the absorption of high-dose oral contraceptives among women with IBD and healthy women, these formulations are rarely used anymore, and no studies have been done on the pharmacokinetics of low-dose oral contraceptives in women with IBD. Another consideration with oral contraception for women with IBD is the risk profile, which is unique compared with healthy women. In women with IBD, oral contraceptives are associated with a 2 to 3-fold increase in risk of venous thromboembolism compared with healthy women. For women with IBD and additional risk factors for venous thromboembolism, careful consideration should be given when considering oral contraceptives. Examples of risk factors include severe active disease, obesity, systemic corticosteroid use, immobilization, and vitamin deficiencies. Furthermore, DMPA injections, which have a black box warning pertaining to the potential for bone loss, may cause reversible loss in bone density in women with IBD, who are already at increased risk of osteoporosis. To initiate a discussion with Rachel about her plans for contraception, you ask her how she will prevent pregnancy until she is ready. Rachel replies that she and her partner use condoms most of the time. To make sure that Rachel is aware of the full range of options and their effectiveness, you ask if she has considered other forms of contraception. You know patients' top considerations for contraception use are usually efficacy, ease of use, and risks or benefits, so you begin by describing long-acting contraception, such as IUDs and implants. Since they are quickly reversible, Rachel would be able to have the devices removed when she is ready to become pregnant. Rachel says that she has never had an IUD or implant before, and she would prefer to try birth control pills first. You offer to prescribe Rachel a low-dose oral contraceptive and begin by giving Rachel an overview of the benefits of the pill. You say, "There are many benefits to birth control pills in addition to pregnancy prevention. Birth control pills are associated with a lower risk of certain types of cancer, such as ovarian cancer, and improved menstrual symptoms." You also tell Rachel that if she is experiencing worse IBD symptoms during her period, birth control pills could help alleviate those. After discussing the benefits with Rachel, you know that you must then discuss the risks. You know that the combined oral contraceptive pill is considered either a Category 2 or 3 by the CDC for women with IBD. For women with mild IBD and no other risk factors for venous thromboembolism, combined oral contraceptives are considered Category 2, meaning that the advantages generally outweigh the risks. However, for women with IBD and an increased risk for venous thromboembolism, such as those with active or extensive disease, corticosteroid use, or vitamin deficiencies, oral contraceptives are considered a Category 3, meaning that the risks for use generally outweigh the benefits. Since Rachel has active disease and is currently on corticosteroids, you know that she may have a modestly increased risk of venous thromboembolism compared with the general population by about 2 or 3-fold. You say to Rachel, "Now that I've discussed the benefits of birth control pills with you, I'd like to go over some of the risks. All women who take the pill are at an increased risk of blood clots. For every 10,000 women who take birth control pills, approximately 7 will have a blood clot, or 0.07%. To put this in perspective, approximately 2 in 10,000 women who don't take birth control pills will experience blood clots." You then say to Rachel, "Since you have IBD and are currently on corticosteroids, your risk for blood clots may be slightly higher than the average woman. Out of 10,000 women who take birth control pills, approximately 20 will get blood clots. It is worthwhile to keep in mind that pregnancy during an active period of IBD is also associated with an increased risk of blood clots." Progestin-only pills offer similar benefits in terms of pregnancy prevention without the risk of blood clots and stroke from estrogen-based combined oral contraceptives. Does that make sense? Rachel says it does make sense and that she doesn't have any questions currently, but she is concerned about the risk of blood clots and stroke. Rachel decides to use progestin-only birth control pills, saying that she feels it's important that she has a healthy pregnancy, so she'd rather wait to get pregnant by using the pills with a lower risk of blood clots and stroke. You continue to discuss common side effects of birth control with Rachel, such as bloating, irregular bleeding, breast tenderness, headaches, and mood changes. You tell Rachel that irregular bleeding will usually resolve within 3 to 6 months, but let her know that she can call you if it causes her a lot of problems. Finally, you conclude by emphasizing the importance of using backup birth control for the first week following the switch. You conclude by telling Rachel that the pill does not protect against sexually transmitted infections like HIV, so she should continue to use condoms for infection protection. At the end of your appointment with Rachel, you review her plan for pregnancy over the next year or so. The first step to having a planned pregnancy is to take birth control pills until she is ready to become pregnant. In tandem, you will work with her gastroenterologist on a treatment regimen to reduce her disease activity. You remind Rachel that this could be a process that requires some trial and error, but the ultimate goal is to taper corticosteroids and limit antibiotic exposure during pregnancy. Since Rachel is anemic, she will also need treatment with iron supplements to reduce anemia. You conclude by telling Rachel that a realistic goal for attempting pregnancy will be about 6 to 9 months at the soonest, and encourage Rachel to plan for this pregnancy to ensure the best possible outcomes. You ask Rachel whether she has any questions about the plan. Rachel replies that she doesn't have any questions, but she is glad that you asked her about her plans for pregnancy because she hadn't realized that there was so much to consider before becoming pregnant. You tell Rachel that you will be checking in with her in a few months to ensure that she is satisfied with her birth control pills, and you encourage her to call you if she has any concerning side effects. Rachel thanks you and says that she'll be in touch when she's feeling better and ready to start considering pregnancy.